Welcome to Roadmap to Residency. Hello everyone, I am Aviras. Welcome to our Club 250 Matchmaker session. We are currently in our neurology sessions. This is Neuroanatomy Fundamentals Part 2. We will be running through some questions with you guys to help you on a journey to 250. So, which of the following best characterizes the primary pathology in this patient's neurological symptoms? A 60-year-old man presents with personality changes, disinhibition, and impaired judgment. Neurological examination reveals frontal release signs, including the bilateral grasp reflex. Imaging studies demonstrate atrophy in the frontal lobes, particularly the prefrontal cortex. The patient's family reports a decline in his social and occupational functioning. Which of the following best characterizes the primary pathology in this patient's neurological symptoms? Degeneration of the occipital lobes, atrophy of the temporal lobes, involvement of the parietal lobes, lesions in the frontal lobes, or degeneration of the limbic system. The clinic the clinical presentation, including personality changes, impaired judgment, and atrophy in the frontal lobes, particularly the prefrontal cortex, is suggestive of frontotemporal dementia. Frontotemporal dementia often presents with changes in behavior and personality and is associated with atrophy in the frontal and or temporal lobes. So the correct option is lesions in the frontal lobes. So this is the a picture of the lobes of the cerebrum here. So here we can see this is the frontal lobe, so which contains the prefrontal cortex and the frontal eye field. Then we also have the premotor cortex here, and then this is the primary motor part, and this is the central sulcus. Now this central sulcus divides the frontal lobe from the parietal lobe, and this is the primary somatosensory area. This is the somatosensory association cortex, and this is the arcuate fasciculus. Okay, now you might be remembering something that I have told you in the neuroanatomy fundamentals video part 1. Now this is the primary auditory cortex. This is the Wernicke's area. So the primary auditory cortex and the Wernicke's area are in the temporal lobe. Also there is limbic association area, which is in the temporal lobe, but the Broca's area is particularly in the frontal lobe. So there is the primary visual cortex area or visual area, which is in the occipital lobe. Now you need to understand, you need to remember what all areas are present in what all different lobes and what the lesions can be if the specific areas will get disturbed. So let's also discuss about the homunculus. Now, if you just remove this all text and you just remember this image, okay, and this color coding, then that will help you to answer almost all the stroke questions in your examinations, which are typically based upon the cerebral hemispheres. Now, the motor homunculus or sensory homunculus are somewhat similar. So if you only just remember one, then that will work for both of you. Or if you can remember both, or you can remember this even the small tiny details, then that will be awesome. So what is homunculus? So homunculus is a topographic representation of motor and sensory areas in the cerebral cortex. Distorted appearance is due to certain body regions being more likely and more visually innervated and thus having an increased cortical presentation. So you can see the area supplied by green is supplied by the anterior cerebral artery. This is the middle cerebral artery, and this color is the posterior cerebral artery. Now we can see that the anterior cerebral artery supplies the hip, knee, ankle, toes, and trunk. Okay, some part of the trunk. Now this area, if there is deficits or in motor or sensory functions in this area, then that means that the defect is in the anterior cerebral artery, and everything else is related to the middle cerebral artery, okay, like the swallowing, jaw, tongue, lips, or you can say face and hand. Okay, so trunk and thighs, trunk, thigh, knee, and toes are ACA. Everything else is MCA. And if there is PC supply is lost, then that will essentially affect the visual fields. So you can also you should also remember about the decorticate or decerebrate posture. So the red nucleus is found in the midbrain and it is responsible for controlling the flexor tone. As a result, damage above or below the red nucleus can give these findings. So decorticate posture, increased flexor tone due to an intact red nucleus combined with an issue upstream damage to the cerebral hemisphere, the internal capsule, thalamus or midbrain leads to the decorticate posture. We can see flexion of the hands, there is adduction, there is extension and plant reflection. Okay, in decerebrate position, there is increased extensor tone due to a non-intact red nucleus. Damage in the brainstem below the red nucleus is likely the cause. And you can see here the flexion, the pronation, adduction, and extension. Okay. Now let's do one more question. Which of the following best describes or best characterizes the primary pathology in this patient's neurological symptoms? A 55-year-old woman presents with a sudden onset of uncoordinated movements, imbalance, and difficulty maintaining a steady posture. Neurological examination reveals intentional tremor, dysmetria, and a wide-based unsteady gait. Imaging studies show atrophy of the vermis of the cerebellum. Which of the following best characterizes the primary pathology in this patient's neurological symptoms? So the degeneration of the cerebral hemisphere, lesions in the cerebral peduncles, atrophy of the cerebral vermis, involvement of the dentate nuclei, or uh, degeneration of the flocculonodular lobe. This is pretty much easy question. So the clinical presentation, including uncoordinated movements, intentional tremor, dysmetria, and atrophy in the vermis of the cerebellum, is indicative of disorder affecting the midline structures. The cerebral vermis is primarily responsible for the maintaining axial coordination. So the correct answer is atrophy of the cerebellar vermis. So degeneration of the cerebral hemispheres can lead to ataxia and other cerebellar symptoms. However, the patient's presentation with atrophy in the vermis suggests a midline cerebral pathology. Lesions in the cerebral peduncles can disrupt communication between the cerebellum and other parts of the brain. However, the specific symptoms described, including ataxia, intestinal tremor, and dysmetria, are indicative of midline dysfunction. Involvement of dentate nuclei are important nuclei within the cerebellum, but isolated involvement of the dentate nuclei will typically present with different symptoms. Okay, now degeneration of the flocculonodular lobe, which is involved in the vestibular function and is not typically associated with the symptoms described in this patient, such as intentional tremor and dysmetria. In summary, the most likely primary pathology in this patient's neurological symptoms is atrophy of the cerebellar vermis. Now let's review the first part of the cerebellum. Now the cerebellum modulates the movement, aids in coordination and balance. The ipsilateral or unconscious proprioceptive information via inferior cerebellar peduncle is received from the spinal cord. The deep nuclei lateral to medial, so don't eat greasy foods. Dentate, emboliform, globus, and fastigial nuclei are there. The medial cerebellum, example vermis, controls the axial and proximal limb musculature bilaterally. Medial structure. Lateral cerebellum controls distal limb musculature ipsilaterally. Tests rapid alternating movements, pronation, finger to nose, heel to shin, gait. Look for intention tremor. So cerebellar input is from the contralateral cortex is through the middle cerebral peduncle. From the spinal cord is through the inferior cerebral peduncle. And the output is from the superior cerebral peduncle, which then goes towards the contralateral cortex. Let's discuss one more question. Which of the following structures in the brainstem is most likely affected in this patient? A 65-year-old man presents with diplopia, facial weakness, and difficulty swallowing. Neurological examination reveals weakness of the right lateral gaze, right facial droop, and uvular deviation of the to the left. Upon seeing the patient's report recent upper respiratory tract infection, which of the following structures in the brainstem is most likely affected in this patient? Medulla oblongata, pons, midbrain, tectum, or cross cerebral. The patient's symptoms, including diplopia, facial weakness, and uvula deviation to the left, are indicative of a peripheral lesion involving the right cranial knobs, or cranial knob 7 and 9 or 10. These cranial knobs exit or have nuclei in the medulla oblongata. The most likely site of the lesion is the nucleus ambiguous, which gives rise to the motor fibers of glossopharyngeal and vagus nerves. Therefore, the correct option is A, medulla oblongata. So this is the picture of the brainstem. Okay, you can see the third ventricle here, the thalamus, the superior and inferior colliculus, the superior cerebral peduncle, middle and inferior cerebral peduncle. There is this is the anterior wall of the fourth ventricle. Okay, now the pineal gland or the melatonin, pineal gland helps in the melatonin secretion and circadian rhythms. The superior colliculi helps in the direct eye movements to stimuli or objects of the interest. Inferior colliculi is in the auditory. So this is the mnemonics that the first aid provides. Thank you for watching. Keep studying hard.